Pleurectomy decortication, usually abbreviated PD, is one of the surgical options available for treating pleural mesothelioma. If your surgeon has recommended PD or you're trying to understand whether this surgery might be right for you, you need to know exactly what the operation involves, how long it takes, what recovery looks like, and what outcomes you can expect. I want to walk you through PD surgery step by step, explain how it differs from other mesothelioma surgeries, and help you understand what you're facing if you choose this approach. I'm Terri Oppenheimer. I've been writing about mesothelioma and asbestos for the website mesothelioma.net for over a decade. I am not a physician and this is not medical advice. But understanding PD surgery helps you make informed decisions and prepare mentally and practically for what's ahead. So let's start with what pleurectomy decortication actually is. Pleurectomy means removing the pleura. That's the membrane lining the chest cavity and covering the lung. Decortication means removing the tumor rind or peel that has formed on the lung surface. The goal of PD is removing all visible tumor while preserving the lung. This distinguishes it from extrapleural pneumonectomy, or EPP, which removes the entire lung along with the pleura. PD is frequently referred to as lung-sparing surgery. And there are several variations of PD. Extended PD, or PD with extended resections, might include removing parts of the diaphragm, pericardium, or other structures involved by the tumor, with reconstruction using synthetic materials. Partial pleurectomy removes pleura from only part of the chest cavity when the disease is localized. Pleurectomy alone without decortication removes the pleura but doesn't remove the tumor peel from the lung surface. This is mainly a palliative procedure to address recurrent effusions. When surgeons discuss PD for mesothelioma, they usually mean extended PD with removal of all visible tumor. Now, who's a candidate for PD? Your disease needs to be confined to one side of the chest without extensive invasion into unresectable structures. You need to have epithelioid or favorable biphasic cell type because sarcomatoid patients rarely benefit from the surgery. You need a good performance status and lung function that's good enough to tolerate major surgery, and there can't be any distant metastases. Even among surgical candidates, patient selection is crucial. Not everyone with operable disease should have surgery. The potential benefit must outweigh the risks and burden. Now, before I go on, I want to ask a quick favor of you. If you find these videos helpful, please hit the like and subscribe buttons below. It makes it easier for other people who need this information to find us. Also, if you have questions or there's a topic you'd like to see addressed in the future, send me a note in the comments section. And make sure you watch until the end because I'm going to give you valuable information on where to find resources that will make a real difference for you. Now, what actually happens during PD surgery? The operation is done with the patient under general anesthesia. It typically takes 4 to 6 hours and sometimes longer if the disease spread is extensive. The surgeon is going to make a thoracotomy incision. That's a large incision along the side of your chest between the ribs. The chest cavity is opened and the surgeon is going to carefully separate the parietal pleura from the chest wall, working methodically to free the entire pleural lining. This is meticulous work because the pleura is densely adherent to the underlying structures. The visceral pleura covering the lung is then removed. This is the decortication portion. It involves carefully peeling the tumor and pleura off of the lung surface without damaging the underlying lung tissue. The lung must remain intact and functional. All visible tumor nodules will be removed from the accessible surfaces. The diaphragm and pericardium are examined to see whether tumor material has invaded these structures, and any involved portions will be removed and reconstructed with synthetic patches. Lymph nodes are sampled or removed for pathologic examination. The chest cavity is irrigated and chest tubes are placed to drain fluid and air post-operatively. Then the incision is closed in layers and you'll be taken to intensive care for close monitoring. What's recovery from PD surgery like? You wake up in the ICU with multiple tubes, chest tubes draining fluid from the chest cavity. There are usually 2 or 3, possibly an epidural catheter for pain control, IV lines for fluids and medications, oxygen support, and a urinary catheter. The first few days, your care is going to focus on pain control, doing breathing exercises to re-expand your lung, and preventing complications like pneumonia or blood clots. You'll work with physical therapists to get out of bed and walk despite any pain you're feeling and the chest tubes. Those chest tubes typically remain in place for 5 to 10 days until the drainage decreases to acceptable levels. Air leaks from the lung surface are common and they might prolong chest tube duration. The hospital stay is typically 7 to 14 days for an uncomplicated recovery and longer if complications occur. At home, your recovery is going to continue for weeks to months. You'll have significant chest pain and tightness for weeks, and all activities will be restricted. There's to be no heavy lifting, nothing over 10 or 15 pounds, and that's for 6 to 8 weeks. There's no driving as long as you're taking narcotic pain medications. You'll gradually return to normal activities over a few months. Full recovery, where you're feeling back to your baseline energy and function, it generally takes 3 to 6 months. What are the risks and complications? Operative mortality, which is another way of saying death during or shortly after surgery, is 2 to 5% when done at experienced centers, but higher at low-volume hospitals. Major complications include a prolonged air leak, which happens to 20 to 40 of patients and which requires extended chest tube duration. You can experience respiratory failure that requires prolonged ventilator support, cardiac arrhythmias, which are irregular heart rhythms from heart irritation, bleeding requiring a transfusion or reoperation, infections, including pneumonia or empyema, which is infected fluid in the chest, blood clots, including deep vein thrombosis or pulmonary embolism, and kidney failure from surgical stress. Most patients do experience some complications. The question is whether they're manageable or life-threatening. Long-term effects can include chronic pain at the incision site, decreased exercise tolerance compared to before surgery, and nerve damage causing numbness or altered sensation. What outcomes can you expect? PD doesn't cure mesothelioma. Microscopic disease almost always remains. The goal is cytoreduction, which means removing bulk tumor to potentially extend survival when combined with chemotherapy or other treatments. Median survival after PD varies widely based on patient selection, cell type, and the completeness of the resection. Well-selected patients at experienced centers might achieve a median survival of 18 to 24 months. Some patients live for several years. The MARS-2 trial showed no survival benefit from extrapleural pneumonectomy, which dampened enthusiasm for aggressive pleural surgery. PD outcomes appear to be better than EPP, but they're still modest. Not all patients benefit. How does PD fit into overall treatment? It's usually part of multimodal therapy, which combines surgery with chemotherapy and sometimes with radiation. Neoadjuvant chemotherapy might be given before surgery to shrink tumors, after surgery, which is called adjuvant chemotherapy, and that kills remaining cells, or it could be both. Radiation might be given to the surgical field after recovery to target microscopic residual disease, though there's limited evidence that this provides much of a benefit. What questions should you ask your surgeon? How many PD operations for mesothelioma do you perform annually? What are your outcomes in terms of operative mortality, complication rates, and median survival? Do you think complete resection is achievable in my case? What would my recovery timeline look like? What alternatives exist? Could I have chemotherapy without surgery or other surgical approaches? How does PD fit with chemotherapy or immunotherapy in my specific treatment plan? To review, pleurectomy decortication, or PD, removes the pleura and visible tumor while preserving the lung, unlike EPP, which removes the entire lung. The operation takes 4 to 6 hours and is done through a thoracotomy incision. Hospital stays are 1 to 2 weeks with chest tubes draining for 5 to 10 days. Home recovery takes 3 to 6 months. Operative mortality is 2 to 5% with common complications including prolonged air leak, respiratory issues, and cardiac arrhythmias. Median survival is 18 to 24 months when the surgery is performed at experienced centers on well-selected patients. PD is generally part of a multimodal therapy treatment approach, usually including chemotherapy. The surgery is really only appropriate for patients with epithelioid disease, good performance status, and resectable tumors. You can visit mesothelioma.net for more information about PD surgery and mesothelioma treatment, or call 1-800-692-8608 or use the live chat feature on our website to speak to one of our patient advocates immediately. As for me, remember to post your questions below, and I'll see you next time.